our expert faculty with us. He is well known to everyone, each and every one of us. He's Dr. Pankaj Surange, sir. He's basically CEO and director of IPSC Pain and Spine Hospitals, IPSC vARSITY. He held very esteemed positions in the past, like the past Secretary of Indian Society for Study of Pain, ex-chairman, World Institute of Pain, founder, member and treasurer of Musculoskeletal Ultrasound Society of India, founder, member and honorary secretary, Neuromodulation Spine Society of India, and international member of Spine Intervention Society. There are many rewards and many awards which he has achieved, like the recipient of Pain Awareness Ambassador Award 2015, recipient of Excellence in Pain Practice Award by World Institute of Pain in 2017, recipient of National Pain Physician of the Year Award 2016, and recipient of Her Highness Rajmata Sindhya Excellence Award. So welcome, sir. I welcome you for this in this webinar. And so the cases that we are going to discuss today will be presented by our SSPP member and a senior faculty of our society, Dr. Hemant Kshirsagar, sir. So, yes. So, Dr. Hemant, sir is the consultant in Encure Super Speciality Pain Clinic, Chinchwad, Pune, Pune International Burn Center, Bhosri, Dinanath Mangeshkar Hospital and Jupiter Hospital. And he's a professionally trained anesthesiologist, specialized in anesthesia, critical care medicine, and pain management. And he's the professor and HOD of Anesthesia, Sainath Hospital, Pune. So I will stop this and I will ask Dr. Hemant sir to please start sharing his slide. And sir, you can please moderate this session, Pankaj sir.
Sure.
And you can direct it anywhere you want.
Sure.
Hemant sir, please share the slides.
Just a minute.
Yeah.
The screen is visible?
No, not till now.
So how many cases you are presenting, Hemant? Just a minute, sir.
2 cases.
Okay. 2 cases. I have 2 cases, sir. Okay. Just Sanjog, you can help me now. Again, I am not able to.
You're not seeing the share thing?
Yeah. Where I should go?
What is the issue?
Now is visible?
Yep. Just make it full screen, sir.
Is it visible now?
Yes.
So I am audible to all?
Yes. Please go ahead.
Yeah, very good evening, ladies and gentlemen, respected my seniors and my colleagues. Today I am going to present very atypical low back pain. Possibly we are getting a lot of such type of cases in our pain clinics, mostly day by day. It's greetings from my clinic. So the day I started my pain practice, I remember this, the great scientist Albert Einstein, what he said, a problem defined is a problem how solved. And that could be the main crux in our pain practice. And that definitely we get a lot of problems to get solved with this. So with permission of my all respected patients, I am presenting with their due permission that I can share their photographs and videos of our patients. So case number 1, he is a 67 years male. He was complaining of severe bilateral leg pain with low back pain. So this was his complaint to my clinic. So basically his history of pain is since last 6 months. Pain score is almost 10 by 10, or you can say 9 by 10. The characteristic of pain is he is getting really a piercing, aching, burning, shooting, and mostly it is constant in nature for whole 24 hours in a day. So basically looking at the pain perspective characteristics, what I feel this could be the nocicepty and neuropathic both. It's a combination of the pain character. In red flags, there is a motor weakness. He was unable to walk without support. Unfortunate part on his side that he was operated for 6 times same lumbar spine surgeries. First surgery it was done in almost 1994 when he had accident. That time he had a history of fall, and he said that time it was a fracture. But presently on his MRI, or sorry, his on his CT, there was no evidence of any fracture. But as per his history, he had a fracture, and that time first time he got operated in 93, 94 somewhere. After that, every almost 5 years, 6 years, he got operated. And last surgery he had been done in 2020. So he is a diagnosed case of diabetes mellitus, hypertension, IHD, and he had permanent pacemaker, which had been installed in somewhere around 2000. Personal history, he is a chronic tobacco chewer, mishri he used to use daily. Pain in relation with the posture, except lying, there is all the time increase. His pain is increasing in sitting posture, in standing posture, even he is unable to walk. During walking, he also gets increase in pain character. Possibly there is also reduction in the motor power. In local examination on inspection, there is a multiple scar at lumbar region. At palpation, there is a boginess. Spatial test, what I can found in especially those patients who got operated and they comes to your point clinic for pain relief. These tests are very difficult to predict because every time if you do these tests, they used to elaborate as if all tests are positive. So possibly in spine, we can test all these Faber, Fair, straight lacing test, facet loading test, sacral thrust test, stoop test, and Schober's test. But unfortunately, I could not perform all these tests in this patient. So my plan was simple plan. There was a 3 settings of epidural adhesiolysis through caudal epidural with facetal and lumbar sympathetic block. So in first setting, we have started is caudal adhesiolysis. As if you see my cursor, the needle has introduced from the caudal space, and I try to inject this contrast. But even after pushing the contrasts are unable to reach above the S1 level, L5 S1 level. The contrast still remains at this level only. So that time we used to give steroid plus Hylase plus 0.9% normal saline. It was almost 20 to 25 cc, but it was unable to travel above this level. So second sitting we have repeated after a month. Again, in the second month, there was a little bit increment of the contrast spread towards at the L5 vertebral body. If you could make out the contrast spread as compared to the previous slide, see this is the contrast spread, which has gone at mid-level of the L5 vertebral body. Again, third sitting we have repeated in the second month. Every month we used to repeat this cycle of adhesiolysis. Again, the contrast spread remains the same. There was hardly any migration of the contrast above this level. So in lateral, you can see the contrast spread up to this screw. There was hardly anything. But this third time, when we have done is basically in this patient, we were unable to perform his MRI because of his pacemaker. Because pacemaker was installed in almost 2000, it was not MRI compatible. So we could not do his MRI. So we have managed this image CT scan only, but unfortunately I don't have his CT images. So when fourth time when he landed to my clinic with again me of a pain, severe pain, burning, he was not happy at all. So that time what I have done, I have tried epidural at almost T12 L1 level. So I thought I could negotiate the whatever fibrosis or adhesions made in that level. But even then, the contrast spread is going up. There was no spread of a contrast downstairs. So the contrast is going still up. It was not going into the what we we wanted. So result was absolutely not satisfactory. So what happened after trying all these permutations, combinations for at least 3 to 4 months? Last time he came to me almost 2 months back. And that time we have done because of this, that there is no contrast flow through the caudal or epidural. So we have tried the interlaminar epidural at L4, L5 level. But unfortunate part, even if because of the epidural needle was of a 18 gauge, and that time you could make out due to maybe because of the fibrosis and all, there was a continuous CSF flow. So this is the CSF which is coming through the puncture site of epidural needle. So even with this, if you could see the previous slide of this patient, see, we have injected contrast through that epidural needle. There was a CSF, but the contrast is not going into the CSF. Look at that. Contrast still remains at the L5 level. But as there was, the fluid was leaking, so we made a diagnosis. Even if there was no contrast going into the CSF, still there is a CSF leak. But patient referred to a higher center for dural patch, and on CT scan, the spine surgeon said most of, I think, L1 screw and L5 S1 screw, they were saying it is out of the vertebral bone matrix. So they have done fixation again with dural patch, and after spending 10-12 days in the hospital, patient went home. And this was my first case. We could take discussion after this case, or I want to finish second case. Sanjog. Hello.
Hello, Pankaj sir.
I think
we discuss this case, and I will take second case then.
Yeah, first we should discuss this case.
Yes. Sir, go on, sir.
So I think in your case, you said he had undergone 6 surgeries, right?
Yeah, 6 surgeries.
And first was 1992.
Yes, sir. Yes.
Okay. And what was the first surgery? That time was fixation was done or not?
No, that time, yes, sir. There was a history of fall. So they have done a fixation with only one level. Possibly he was telling it was at around L4 and S1. These 2 level fixation.
Okay.
But since then, since 94, he never got pain relief even after these 6 surgeries.
Basically, they started fusing other parts also.
Yeah. That's why they started fusing again. Every time they used to come and they used to fix one more vertebral level above.
Okay. All right. So basically, sir, we can call it as a failed back syndrome, right?
Yes, sir. Absolutely.
Failed back syndrome. And whatever you mentioned is that the type of pain, what you're mentioning is more goes in favor of the neuropathic kind of pain.
Yes, sir. Yes, absolutely.
Only one thing which is like which is not coinciding with the, which is not, we cannot relate with the neuropathic pain is the patient is having there is no resting pain, right?
Yeah.
When you're saying that patient is having pain only on sitting or standing or walking.
Oh, yes, sir. Yes, right.
There is no pain.
Okay.
Which doesn't go in favor of the neuropathic pain.
Okay.
Patient with the neuropathic pain, they'll have the resting pain also.
24 hours they have a pain. Okay.
So because somewhere you mentioned that he was having no pain at rest, right? So which is not going in favor of that. Pain on movements, sitting, walking goes more in favor of the somatic kind of pain, right?
Yes, sir.
Okay. So, and patient, you said that the pain is more, the first thing you said is the leg pain is more than the back pain.
Yes, sir. Leg pain is, radiating pain is more as compared to the back pain.
And okay, so probably, so when was the last surgery was done?
So basically, last surgery because of the CSF leak. And that time they found on the CT that there is a migration of 2 screws.
So when he came to you, that what was the last surgery that time?
Last surgery in 2020, sir. Again, it was a fixation.
Okay, and he came to you in 2022, 23?
24, sir.
24.
Month of May, possibly. Month of May. Yes, sir. Yes.
So 4 years after the last surgery?
Yes, sir. Yes.
Okay. Okay, all right. So I think few things what we need to understand here is that when you're saying that adenolysis, right? Adenolysis actually may not be a good term here.
Okay.
Why? Because I'm saying this because immediately after the surgery, the patient comes to you after maybe 4 weeks, 6 weeks, maybe 2 months. We can expect adhesions over there,
Okay, sir.
right? So that time we can say there's adenolysis because these are most of the inflammatory adhesions are there,
Of course, sir.
right? Initially, for initial 6 months, 1 or 2 months, we have inflammatory adhesions. As the time passes, right, these adhesions they become fibrotic.
Yes, of course, sir.
Right, it becomes fibrotic. Okay, so and fibrotic tissue, if you have seen redo surgeries, I'm sure that if all of us are anesthesiologists, we must have conducted all these surgeries, post surgeries also. So even now when we do endoscopic procedures also, we see that fibrotic adhesions. These fibrotic adhesions are so adherent and they're so thick, they're so tough. Okay, so actually you have to cut them with the cutters.
Okay.
Right, when we use this endoscopic procedure, we do the annular cutter, right? We use annular cutters and we use this plavum cutters. So when we find these kind of adhesions, fibrotic adhesions, actually we cut them. They are so hard.
Yeah.
So with just the medications, we should not expect that it will have a adenolysis or the fibrinolysis.
Okay, sir.
Which is very difficult after 4 years of surgery. Okay, so that is one thing which we should remember because there are some case reports and some studies which also shows that these metallic catheters are there which can cause this adenolysis, right?
Right.
But again, they are only for the early stages, not when the adhesions become fibrotic.
Yes, sir. Yes.
Okay, because it's not possible. Okay? So I think we should not use that word adenolysis. Maybe what you are saying is that you had a good flow of the contrast after doing first procedure and second procedure and third procedure. So
then it was the contrast flow was not there. Even after second, third setting, the contrast remains at till L5 vertebral level. It has not gone up.
So that means it was a thick fibrosis. That's
yes,
why.
Of course. Yes, sir. Yes.
And patient never had any relief. Every time you are using some depomedrol along with that? You're using some depomedrol?
Yes. I used to use normal saline, Hyles, and depomedrol.
Okay. All right. And with that also patient had no relief?
No relief, sir.
So that means it is not the neural structure, inflammation of the nervous structure is also not there.
There was one image, put it on the slide, sir. There is a L4 root. It was very edematous as per the contrast image, sir. So I have that image. Possibly I can show you that image. This last image, sir. This one. This is the root. Is it visible?
Yeah, it's visible. So here also I'd like to say one thing that when you say now root, now root is always inside into the epidural space.
It is in the?
It's in the epidural space inside. The root is like it is basically you have pedicle, right? You have pedicle over there. So when the root comes out of the dura, it goes and gets stick to the pedicle, inside of the pedicle, right?
My needle is just below the pedicle, sir.
Yes. So inside the pedicle. If you go little up, and that is your root actually.
Yeah.
No, inside.
Okay. This way.
Under the medial to the pedicle.
Yeah.
Medial to the pedicle is your root.
Yes, sir.
Okay. So when it comes out, then the ventral lemma and the dorsal lemma, they comes out. So say root as per se, they are basically inside into the epidural space.
Okay, sir.
Into the canal. Okay. So that is what our target is when we do the transforaminal, right? Our target is the nerve root.
So you are going medial to the pedicle.
Yes, medial to the pedicle. Whatever we see in the medial to the pedicle, right? Medial to the mid-pedicular line is all your root.
Yes.
Okay.
Understood?
Yes, sir.
And whatever we see this inflamed part, when we say that inflamed part, this could be your DRG. That could be your DRG. What you are seeing here is the
EDR.
Yes.
just which is just below the under the pedicle. That is a dorsal root ganglion.
Yes.
So it should not be at the inflamed nerve. It may be your DRG. What you are seeing here. Okay.
Yes.
So here also, if you look at this, your contrast is not going inside. Again, could be because of the severe fibrillary tissues over there.
Yes, sir. Yes, yes.
So all the contrast is coming out of the foramen.
Yes, sir.
Right? It's not going and covering the root. So that could be because of fibrosis. A lot of fibrillary tissues, and which we should expect that after multiple surgeries, expecting that. Right?
Yes, sir.
And when you do this interlaminar, I think you said you did a interlaminar also, right?
Interlaminar, sir. That was last.
So only thing is we have to be careful about interlaminar over here, because after this surgery they have done. If you look at this, they have done laminectomy also. Laminectomy also. Phlegm is also gone from there.
Yes, 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 sir.
From there, right? And if you look at the MRI of these patients, when you see the MRI of the patient,
actually, we don't have MRI, sir.
Yeah, I know. In this case, it's not there.
Yeah.
But normally, what happens when we have such extensive this thing, laminectomy is there, no? Where the phlegm is also removed, you know?
Decompression, laminectomy, and fixation.
So laminectomy is phlegm is gaya pura, which is right?
Yes, sir.
So there is a support system in the posterior part.
Yes, sir.
When there is no support system, what happens? If you look at the MRI of those patients, you will see that dura will start going to the posterior side.
Okay.
And because of this, they lost the support, the dura gets thinned down. अब देखोगे कि dura वहाँ पे थोड़ी swell हो जाता है.
बराबर है sir.
Right, and it starts going to the posterior side. Right, so that is why that could be the reason when we do interlaminar, we should be very, very careful because there is no phlegm there now.
Yes, sir. Yes.
There is no epidural space, in fact. Okay, there's no epidural space now because phlegm is out, lamina is out, everything is out. So what is there is directly is your fibrillary tissue.
Yes, sir.
Muscle, fibrillary tissue, and the diet is a
dura.
Okay, so interlaminar we should not try in such.
That was my mistake actually, sir. Because the patient was not relieved, so finally I thought let it go like this.
It's really wonderful that you are presenting a patient where you did multiple things and you didn't get any relief, and you are presenting that case. That is most important part. Success we all celebrate, right?
Yes.
But telling your destiny that I failed in this procedure and failed in giving relief to the patient, that needs guts, right? So there are multiple learnings right? I think most of the people who are there, they are also freshers also maybe there. So they will learn a lot of things out of this. Okay. So, and then after they did again
dural patch with fixation, sir, again.
Fixation. Again for the fixation.
Yes, sir.
Basically, they readjusted the screw, right?
Yes, sir. They readjusted the screw. Fixation means readjustment of the screw.
At what level they did a readjustment?
Sir?
At what level they did a readjustment? What
Possibly
level?
it is the L1 level, sir. Possibly top of the screw and at S1 level. Because if you see the screw at the S1 level, they say it was migrating on right side. This way. This screw. Because this one is in the pedicle exactly in the position, but this has been migrated downwards.
We cannot say it is migrated downwards because once we go inside the pedicle, actually we want to go slightly more medial. Okay, because then we get a good fixation over there because the sacrum is like this.
Yes, sir.
Actually, when we do this fixation, we have to go slightly medial, especially in the sacral region. Okay, in the lumbar region, we want to use the cortical bone.
Okay.
We want to go more.
Yes, sir.
We don't want to put everything screw into the medullary bone.
Okay.
So that's why we go straight in the lumbar region.
Yes, sir.
In the sacral region, with the S1, we go slightly more medial. Okay?
Medial and downwards.
Yeah, medial and downwards, yes. If you see AP, it looks downwards.
Yes, sir. Yes,
It's
sir.
not downward. It is in alignment with the sacrum only.
Yes.
But when you see AP, it looks that we are going downwards. Because the
Yes.
orientation is like that.
Yes, sir.
That's why. So, okay, good. So they did a dural repair and they did a, I think,
Yes, sir. Readjustment of the screws.
they must have done some this thing also. They must have cleared some fibratory tissue also from there.
Yes, sir. Yes.
That is why the patient had immediate pain relief after that.
Yes,
So
sir.
probably that they must have done some adenolysis or some fibratory tissue, right? They must have removed that. Okay, good. So similarly, I just had one case. We are going to present that case also. We are reporting
Yes.
that just 2 months back, I did an endoscopic decompression. It was wonderfully we removed that. Patient was having motor weakness, everything was there. So immediately after that, second day only, patient started feeling better and he was okay, pain-free, absolutely fine. But he came back after 2 months, almost more than 6 weeks after that. And gradually he started developing pain and he came in a severe pain.
Okay.
We got his MRI done, again fresh MRI, contrast MRI, we did a contrast MRI. And we couldn't find much of this. Just a small piece was there, which was possible because of it was left inside. It was severe compression. But pain was very severe. So initially I thought it is maybe some, this is possible, right? Reherniation is possible after an endoscopic, right? So I thought okay, it is a reherniation which has happened and the small piece has come out and that has caused inflammation. That's why he's getting severe pain. So tried, I thought okay, let's go for the transforaminal S1. I tried from the S1 foramen. Same thing happened. Contrast was not going inside.
Okay.
So I went through the Campbell's approach to target S1 from inside, right? From alpha S1 level, I tried a Campbell's approach. Again, nothing happened. Contrast was not going inside. Okay. Then I tried a caudal. Then I put a caudal. I put a catheter. Again, same thing happened. It stopped over there. It was going on the left side, beautifully on the left side, but nothing was going on the right side. Absolutely zero contrast on the right side. So I could make out that there is something wrong inside. Nerve is getting entrapped somewhere. So, and must be swollen. So I again did a endoscopic. And same thing happened when I went inside to the same channel. It was so fibrotic that I had to actually cut everything, all the fibrotic tissues from there.
Okay.
And the moment I opened this fibrotic tissue, the nerve was like almost 3 times the size what we see normally. It was totally red hot, totally edematous. It is because of this entrapment of the nerve root within that fibrotic tissue, the nerve gets swollen and then it causes compression on its own. Okay, because they get swollen, no? So that also hampers the circulation, everything. Then patient was actually into severe pain because of this. It is just because of necrosis, sign of necrosis of the nerve. But it was good that we just opened it, and the moment he opened it, patient had an immediate pain relief on the table. We could see that nerve root swollen up, and so through that only which injected the depomedol there. And in 2 days, patient was fine. Patient was okay. Okay, so these kind of fibrillary tissues are there. They are responsible for these kind of pains. But in your case, yes, definitely could be the reason why when they cleared everything, they must have reopened it. They must have done the fibrosis. They must have removed that. Nerve must have opened up, and that's why the patient was having good relief immediately after that.
So there is one question in the chat.
Yes.
Is this the ideal case for spinal cord stimulation? And I'll just add one thing to it. If it is, then how difficult is spinal cord stimulation in such cases with severe fibrosis?
Yes. So whenever we target the lower lumbar region, right, we don't put our leads in the lumbar region. Right? If you see that chart over there, for lower lumbar region, if you're targeting L4, L5, that is the target over here. We target T10, T11, T12, right?
Yes.
For the spinal cord stimulator.
Yes.
So it's not going to be a challenging case because you are going as it is, you are going putting a lead in the upper segment, lower dorsal segment. So it's not going to be a big challenge over there. Controversial here because patient is having severe pain but it is not typical of the neuropathic pain,
Hmm.
right? And also there were no features of CRPS also,
Hmm.
right? The CRPS features were not there, and typical neuropathic pain was not there because resting pain was not there at all.
Hmm.
So there was something mechanical which was causing the pain.
Hmm.
So in this case, definitely spinal cord stimulator is not ideal for this patient.
Okay. Okay. Hmm. Okay, there are no more questions in the chat. If
One more question. Just now popped up. One more question.
what could have been the better management in this patient?
Whatever he did was right. This is what normally we do, right?
Yes.
We are suspecting that there's inflammation inside and no root inflammation is there. This is what we do, right? The
Yes.
only thing what we did not do well is that interlaminar thing. That is the only thing.
Yes.
But otherwise, this was the ideal condition to give a quadrilateral, right?
I
And
have one question.
since the
Yes.
patient
Yes.
did not have any back pain was not there. So normally, most of the patient they will come with the back pain after fixation surgeries, where we had to go for the fasciital or SI joint. All those things are there, but in this case, definitely that was not there. It was typical of the regular pain, right? Leg pains. So this was good. This was good. Whatever he did was, I think, it was ideal. And he could make out that there's something wrong inside, and patient needs a open surgery in this case, definitely. And after the CSF was leaking, so obviously we had to open that case.
Okay, there are no more questions. We can go ahead with the second case, I think so, sir. Yes, Hemant sir, we can start with the
Just
second
a
case.
minute. Just
Yeah.
a minute. I lost my presentation.
What happened?
Just a minute. I'll
Okay.
start. Yes. So this is my second case. She's a 64 years female, obese, and she was complaining of severe pain at private parts and mostly at the genitofemoral nerve distribution along with low back pain. That was her complaints in my OPD when she landed in my OPD. So she was giving this history that there is this pain since last 6 to 8 months. Pain score is almost 9/10. It's very aching pain, burning, shooting, and again it's constant in nature. So possibly I thought it could be again it's a combination of nociceptive and neuropathic element both. She was operated on lumbar spine surgery. It's just decompression and this one ligamentum flavum, excision of ligamentum flavum and decompression. This surgery had been done 1 year back. So she was very obese lady. She was a case of diabetes mellitus, hypertension, hypothyroidism, and she had history of psoriasis. And for that, she was taking treatment for psoriasis, and she was a case of atrial fibrillation, multiple medical issues with her. So as per her history, she was telling me the pain is continuous throughout day. There was no relieving factor. Even rest also could not stop her pain. So there was no any red flags. Her motor power normal. Everything was normal without any neurological. This one was in red flags. So in initial, as she was telling that she had pain in private parts and she had a spine surgery almost a year back. So we could make out as a female obesity. She was telling me initially the pain is more when she used to sit for a long time. So we thought possibly it could be because of pudendal neuralgia. So we done bilateral fluoroscopic guided pudendal nerve block with caudal epidural. After 2 months of follow-up, In local examination, we have seen on inspection there was a scar at lumbar region. Pain at private parts more on left side through 30 to 40% relief after our pudendal block and caudal epidural. Now she was telling me there was new symptom that she was getting severe right leg pain along with positive SLR test. So we have advised her to go for MRI. In repeat MRI with hip, because she initially was telling me there is a pain at hip joint also. Possibly she was locating the pain at hip. So we thought it could be a hip pathology as she was obese, not able to walk for long distances. Most of the time she was bedridden. So, but MRI clearly suggested that she has L3, L4, and L4, L5 post-laminectomy status with pubic osteitis. So again, we made up our plan that we could go with simple thing, 3 settings of caudal epidural. Again, as sir said, we could not use this terminology adhesiolysis because the surgery was almost a year back. So, but we thought we could go with the catheter adhesiolysis with epidural catheter tunneling. But here we made one change in this patient. In previous patient, what we have done our adhesiolysis at 1 month apart. So we have taken 3 months to do adhesiolysis. But in this lady, what we have done, we put a epidural catheter and we are doing adhesiolysis every day as we kept catheter, 18 kg epidural catheter, and we used to push contrast plus normal saline, Hyalase and steroid every day. So what we have found in this, if you see the right side picture of my screen, the contrast is sprayed up to S1 vertebra. On second day, the contrast has gone up to L5 vertebra. And third day, the contrast had been reached above the L5 vertebra. So in this patient, we got a better relief. She was finally happy and went home. Just 2 days back, she came to my OPD and she was telling me she is getting not 100%, but she is much better, 70 to 80%. So that was her feedback. So this was my second case. Case is open for discussion.
So Hemant, you said so initial presentation was like a pudendal neuralgia type.
Yes, sir. Yes.
Initial presentation was different, and after
Yes,
that, you presented different symptoms, right?
Yes, sir.
Okay, so I think what when you're suspecting pudendal neuralgia,
yes, sir,
you did a fluoroscopy guided. I think my suggestion is that for pudendal nerve, it is better to use an ultrasound.
Yes, sir.
Rather than using a fluoroscopy.
So we tried in this lady ultrasound, but her weight is around 120 kg. So we could not make out the things.
You did what you gave in this pudendal, you did some diagnostic block first?
Yes, sir. It was a diagnostic block. And that too, with diagnostic block, she got good relief for 1 or 2 months. She followed me after 2 months after the procedure.
So one thing here we to be very clear that whenever we do any diagnostic block, we cannot combine that with any other procedure.
Okay.
Because otherwise diagnostic this thing is lost.
Yes, sir. Value of diagnosis is been
right. Model will cover all these S2, S3, S4, everything, right? And your pudendal nerve is only coming from that side, right?
Yes, exactly. Yes,
for that also, right? So how will you come to know whether it was caudal which was effective or it was pudendal nerve?
Yes, sir.
Diagnostic was effective. So we should not combine two. Firstly,
very well taken, sir.
And if the patient is having severe pain, so with just one single diagnostic block, patient had a good relief, right?
Yes, sir.
Okay. There is one component which is called myofascial pain component.
Yes, sir.
Right. So these are the patients who may present with this Levator-Anai syndrome. If you heard about the Levator-Anai syndrome.
No, sir, not Levator-Anai
syndrome. Okay, they also present with similar kind of pains.
Okay.
They'll have this constant pain, and usually these pains they get aggravated with three maneuvers, basically by urination, by defecation,
yes, sir,
and with the intercourse. Okay, so they will have this kind of myofascial component.
Yes, sir.
So there are basically three, what you can say, three group of these muscles. Okay, and these three have different roles. So depending on which group of the muscle, within the muscles having this myofascial component is there, they will have this trigger factor.
Yes,
Some
sir.
patient will have with all the three, if all the three muscle groups are involved. Some patient will have maybe just with the urination. Somebody will have only with the defecation, or somebody will have with the intercourse. So that also, there's another class of the. I'm just telling you that because we should consider that also when we are discussing about the perianal pain and these area pain. Right? So that is again another important thing. If it is pudendal neuralgia, so why I'm saying this, because with one single diagnostic block with local anesthetic, there is a possibility of having good relief if it is a myofascial component is there. Okay. But for neuralgia, it is very unusual that with just a diagnostic block, patient will have a good long-term relief. Okay. So could be there may be some myofascial component was also there. There may be some trigger point or something was there, myofascial band was there, which was leading to this kind of entrapment of this nerve. When you get the local anesthetic, you must have released that myofascial component, and that's how the patient must be having the good relief. That could be the possibility. Okay, but otherwise, in these cases, we have to go for the pulse radio frequency. If they have a pudendal neuralgia, actual pudendal neuralgia, after diagnostic block, we have to go for the pulse RF, only pulse RF, no radio frequency, no conventional RF, no ablation over here. Okay, because we have this external sphincter which is supplied by this, right? So we have some muscular supply, right? So we cannot give the conventional RF. So we have to be only with the pulse RF. Or yes, what you are saying is add multiple infiltration of this pudendal nerve with the dipomedol every 7 days, not every day, but every 7 days, 3 such sessions. That is also mentioned, I think, somewhere. I have read it somewhere. I have not done that, but I read it about it. Some people are doing that also, and it's mainly because of what? The steroids are basically going to help what? They are going to act as a membrane stabilizer.
Membrane stabilizer.
Right? So whenever we have this neuralgia kind of thing, so when you inject local anesthetic along with that steroids, it acts as a membrane stabilization, and that basically resets the neural structures. So that could be the possible mechanism of action of these multiple steroids infiltration around the pudendal nerve. So one thing is that we have to remember, don't combine any two procedures, especially if you are doing diagnostic.
Yes, sir. Got it.
Absolutely not required. And in the second time, when you said the patient was having radicular pain, that time you did a caudal epidural, right?
Yes, sir. Yes.
And you put a catheter inside, and you were doing. So for how many days you gave this epidural infiltration?
3 days. 3 days, sir.
3 days. And every time you use how much dipomedol?
Dipomedrol somewhere around 140 milligram, not more than that, because he's already obese patient, multiple medical issues. So we thought only with a normal saline, I think.
So okay, and the patient was having only pain on the one side only, right?
Yes, sir. Yes.
So okay, and why you chose for the caudal, not the transfemoral?
Because previous surgery, sir, I thought with the caudal, she had a complaining of genital region pain plus lumbar region back pain. So I thought caudal will suffice both the things.
Okay, that's okay. We can do both way. But definitely because transfemoral is more selective.
Effective, okay.
More selective, and because when you use a caudal approach, you have to use a larger volume. And when you use just 40 milligram dipomedol, you have limitation with the drug dose, and you are diluting it into maybe 5 ml, 10 ml, whatever it is. So the effective dose reaching your target nerve is very less.
Okay.
So that's why it is always better to go for the transfer approach, so that you can deposit a concentrated drug over there. So that is always advantage over the caudal neuroplasty. Okay. Another.
Just can I interrupt one? Pankaj?
Yeah.
Yeah, Uttam here.
Uttam.
Hi. Hemant, just
Yes.
a suggestion. Whenever you are suspecting pudendal, just do a PV for every patient. That is
Okay.
just my suggestion for, because
Yeah.
that
Very
is
well
my
taken.
experience that many a times once you do PV and if you try to compress the nerve against the ischial tuberosity, you will get tunnel signs positive. And
Okay.
what I think when you presented the case, your pain was getting radiated to genitofemoral and the MRI was showing osteoitis pubis.
Yes.
So osteoitis pubis, many a times you get a genitofemoral irritation and you get a pain on in that region. So
Mm-hmm.
maybe that the first initial I don't know how it went off,
Mm-hmm.
if it is because of the osteoitis pubis, but because you never give anything over there.
No.
So that are the just two remark I wanted to
Yeah. Very
do.
well taken your suggestion.
At times, your SI joint may also cause you
Yes.
Okay.
the anterior joint involvement is there. In
Mm-hmm.
most cases, you may have this perianal kind of pain.
Okay.
Okay, so you have to, like, only thing is that uh, you cannot do any diagnostic over here because you have to rely on the interarticular only.
Okay.
Like, okay, because they are supplied with the ventral rama over there, right? Anterior joint. So you cannot reach there. So for that, you have to rely on the interarticular lignocaine injection only. Okay, like for the SI joint, posterior joint, we do the diagnostic, right, with the lateral branches of S1, S2, S. But here we have to go on with the interarticular only.
Okay.
We have to give it good local anesthesia inside the joint, inside the capsule joint. Once we reach there, then we can give just local anesthesia and we can see that it is diagnostic positive or not.
So there is one question in the chat. Is it right to give steroid every day for 3 consecutive days?
Why not?
I don't think there is any problem in that as long as you are keeping a dose into consideration, right? Like he's giving just 40 milligram.
And
That's okay. I think
A lot of our patients, they are taking steroid for months together daily. Vicilon, Pradnya. So I don't think so there will be any issue. And the quantity we are using, it's a very minimal dose. Actually, sir, most of the patient in pain practice now, especially patient, they have a lot of myths about the steroids. I don't know why it came wrong, but everybody was, even patients were asking us, so you are giving only steroids. So we need to clear this myth actually.
so. For that, the best way is that whenever you explain to the patient the
Mhm.
procedure,
Yeah.
you yourself tell them that we are going to use this medicine.
Okay.
Okay, this is a locally acting medicine. It is not going to harm you much. Don't worry about that. Because people have a myth about not about the medical steroid. They have a myth about these bodybuilding steroids, right?
Yes, sir.
So they have that thing in mind most of the time. Okay, these are those kind of steroids जो हमारे जो cracks होते हैं ना वो देते हैं वो
And,
energy वाला है ना
yes. Anabolic steroid, yes.
so because what they do is,
Anabolic steroids.
yeah,
Anabolic
anabolic steroid,
steroid.
because they don't tell the patients, right? They don't tell patients, and the patients usually we see from these localities where these cracks are rampant, and from there only we get these patients with the AVN, not a patient we get with the AVN. Right? और वो बताते हैं इनकी हिस्ट्री. व्हेन यू टॉक अबाउट हिस्ट्री देन दे गिव, हाँ हमको ये देते थे, ताकत की दवाई देते थे, इंजेक्शन देते थे, राइट? तो वहां से वो मिथ फैलता है एंड दे थिंक दैट. सो यू हैव टू जस्ट टेल देम कि whenever you explain them if you are going to use steroid, tell them before they ask you. That is always better.
I just tell one more in one sentence ki we are doing very targeted procedure and we are placing the drug where it is needed,
It's
and
required.
that's why we are using very low doses.
So one more question I want to ask you. What is the role of regenerative medicine in such operated patients? Those who comes to your OPD for even after surgery they didn't get relief. So is there any role of PRP or growth factor concentrate, stem cells?
See, what we are going to do with the PRP and other growth factors is only fibrosis. We are going to develop fibrosis over there.
Okay.
Right? So that will add into the fibrosis actually. So I don't know about others, but would not like to go for the PRP or the regenerative for the post-operative patients.
Okay.
Maybe intradiscal, if you have an annular tear, you can deposit the PRP over there. So that is our aim, because we want to create a fibrosis over there, right? Because annular tear is there, there's an inflammation. We want to take care of that. We want to seal that tear. For there, we want fibrosis, but not outside, right?
Yes.
So I have a reservation on using regenerative interventions for the surgical.
Okay. So have you treated, what about the osteitis pubis in this patient?
We have not
This can be
treated
an
it.
accidental finding, or
No, it was accidental finding on MRI. So as Uttam said, possibly we missed it. We could have done more clinical examination of that area, particular area.
But the patient was having bilateral symptoms, right? Patient.
So this patient has an unilateral symptoms. What Uttam is saying is correct. So clinical examination is more important, and I think we are lacking in that part, honestly. We need to learn a lot of things about
No, but yet sometimes I have come across one patient with osteoarthritis pubis and it turned out to be tuberculoid.
tuberculosis.
So don't even
But
try
we need to keep all these things in our mind.
Yeah, before anything, injecting any steroid or anything in the osteoarthritis pubis, just keep that thing in mind, because your patient was diabetic also.
Yes, of course.
So I don't know whether that is whether that is the cause. I don't know. I'm just highlighting that thing because I have come across with the same symptom with the osteoarthritis pubis, and that turned out to be the tuberculosis.
Even most of the male patients are there complaining of the pain at penile region. And they didn't get any reason for that. All the tests, most of the time they used to go to neurosurgeon. Neurosurgeon treated them for 3 months, 6 months, and finally they referred that patients to us. So it's very difficult to convince them, very difficult to tell them the procedure and all. So it becomes really a pathetic thing for us. So what we could do for this?
For what?
Pelvic
Male
pain
patients. Male patients. Male patients, sir. Pain at testicular region, genitourinary.
Cognitive behavioral therapy.
That is the final step. Huh?
They don't accept it, sir. Basically, they want something. They want basically a diagnosis. What is my diagnosis? Why I'm suffering for so long? No doctor in the world is treating me for this pain. So this is the statement they used to give, sir, in our OPD.
So give the diagnostic and then see.
Okay.
Give the diagnostic and see whether the patient is having relief or not, whether it is coming from there. Because if it is actually because of that, then definitely patient will have this pain relief. The diagnostic block, I think, that will give him also something that yes, there is some structural deformities there.
So there is one comment from Dr. Manas that patients of ankylosing spondylitis also have osteitis pubis, and we need to rule out that also.
Okay.
Yes. There is some cluneal nerve block. Cluneal nerve block, I don't know in this case.
But while cluneal will affect the pelvic area, it will go to the buttock.
But you people, you are using cluneal nerve blocks for any of your patients.
The cluneal nerve block really works very well when we have this, especially after these fracture cases at the L1, L2 level or T12 level.
Okay.
Right? These are the patients who may present with a severe pain in the SI joint area. We see that it is a sacroiliac pain actually. It is actually the cluneal nerve involvement which gets entrapped over there, and that causes this kind of pain.
Okay.
This is commonly seen with this kind of
Yeah, cluneal just the cluneal nerve. I had an interesting case which I published a paper also from that. The cluneal nerve one, he was a driver and he was having some claudication like symptoms in the buttocks and the thigh. And the patient went to spine surgeon, and they suggested some disc there because MRI was showing some disc because there was a claudication symptoms. So we did a ultrasound guided hydrodissection of the cluneal nerve, and the patient got a good relief. So we presented a unusual cause of back pain and leg pain. Published that paper about that. So it turned out to be cluneal. So fortunately, that time we were not using the ultrasound too much. That time Ravi Kalathur came to Pune and we performed that under his guidance, and he got excellent relief after the cluneal nerve hydrodissection.
Similar presentation is with the superior gluteal nerve also.
That's true.
Also present with this kind of hip pain and thigh pain. And that pain is actually really severe pain. Superior gluteal nerve.
So these patients can present with deep gluteal pain syndrome like symptoms also.
Again, hydrodissection works very well. We have also done such cases. Yeah. Hydrodissection.
Okay. Great. So there are no more questions in the chat box. If sir, you want to sum up these two cases.
So we'll have to, so for everything, like basic things we have to remember. First, a diagnosis is really important. Examination is really important. Okay. Don't be afraid of getting a MRIs wherever possible or CT scan wherever possible. Especially after post-operative, we should always go for some CT or MRI. If CT is not possible, MRI is not possible, then CT scan. Because a lot of times this is going to happen that especially the youngsters, when they will have these patients, they will have also referred patients, right? After surgery, now, okay, go to this pain specialist and get a facet lagwa lo ya foramen lagwa lo ya fir order lagwa lo types, right? So, but now whatever you are doing, we must remember that you are a pain physician. You are in a super specialist category, right? So you have all the rights to examine the patient properly.
Yes.
Have all the rights to get the patient investigated. Okay. And you have to make your own diagnosis. Don't go by the diagnosis which is given to you. So that is really very important. Prepare a diagnosis. Yes, definitely there are some differential diagnosis will be there. For that, we have diagnostic blocks are there. Okay. And interventions, yes, they do fail. They do fail. So don't be afraid of failures.
Yes, sir, of course.
They do fail. Discuss with them, with your seniors. Don't be afraid of presenting such cases. He has done a very good job of presenting such cases. So keep discussing with your seniors. Koi nuksan nahi usme. And few things we must avoid this, like people when in the WhatsApp group, normally what we see is that somebody will put one case and there will be around 50 procedures there, right? Try this, try that, try this. Right? They are playing with the guinea pigs, right? These are patients, real patients. Somebody is telling you about the problem he is facing, and you start basically pulling that person down. That should not happen. So this is basically for the seniors. So don't pull them down. They're asking something, just help them. Okay? And never ever say, try this, try that. होता है ये एक कोई केस डालता है वो 10-20 प्रोसीजर नीचे आए थे उसके वो बेचारा वो कंफ्यूज हो गया है ना so ask them if somebody is putting some case, ask them what is the MRI finding, show the MRI, show this, whether you've done this or not, whether you have checked this or not. Ask that. Don't start putting straight away that try this procedure.
Yes.
Okay, that is all from my side. So
thanks a lot, sir. Your wonderful suggestions. Very informative and very helpful in our day-to-day practice. It's wonderful. Yeah, sir.
We have our president of SSP, Dr. Pradnya ma'am. Pradnya ma'am, you want to add something?
Are we moving to the next case or?
No. We have two cases. We had two cases.
Two cases. Okay. Thanks a ton, Dr. Hemant. You were really wonderful. These cases were very interesting, and there was a lot of learning involved in all the two cases. So looking forward to listening to you more often, actually, because you seem to be having a very good experience on these cases.
Thanks, ma'am.
And thanks a lot, Dr. Surange. We could really understand the way you discussed all these cases and put forward the very positive points, and from whatever your expertise was shown through whatever discussion we had, and all the learning objectives of today's webinar were achieved as per all of us. So thank you very much, Surange sir.
Thank you, sir. Thanks for the opportunity.
Thank you, madam. Thank you, madam. Anybody else wants to add something? Then they can do it now. If not, then I think so. We will end this session. I think so. It was a very, very informative
Very.
webinar. Very difficult cases. We actually see those cases on day-to-day basis, and we are confused what to do about those cases. So this will be a guide. This webinar will be a guide for treating all those kind of patients. And I personally want to thank Pankaj Surange sir for giving his precious time for this activity. And we will definitely love to see him again and again for our SSPP activities, for his guidance and for the light that he has shown to all our SSPP members. So I want to thank him once again. I want to thank Hemant Shah for presenting such wonderful cases. And just as ma'am said, you should present more in further activities. So with this, I think so we can end this webinar session, and we'll again meet for our next webinar, maybe next month end or in November month end. So thank you, and we'll take leave.
Thanks a lot.
Thank you.
Thank you.
Thank you. Thank you. Thank you.
Thank you.